yesterday is practice, so it should go well. So thank you for coming. We had a big turnout yesterday as well as today, and the other lecturers who are here today are nurses and physicians, some of which are here locally and some from far. And I think from my seeing yesterday, it's a good combination to try to get everybody up to speed on what's going on in neurology and especially in stroke care, how to approach it these days, and how to integrate neurology with the ED, nursing, nurse practitioner, and the medical staff, which has become very, very important. That's what I would like to see. Oh, it's back, almost. So I'd like to start by just saying I have no disclosures to make. Try to get it back. I don't know about the people in the state and Assembly and Senate that are being asked to make disclosures these days, but I don't have any. Thank you. My talk is going to introduce us to what I feel is a very opportune topic in the treatment of stroke with new techniques, endovascular techniques, and why it's so important now, and to try to put all the things that we've been doing nationally into perspective, and tell you about the incredible timing about treating stroke now in this community now. If you look at the use of what's called thrombolytic therapy for the use of treatment of stroke, it really started in the United States in 1995, the end of 1995, when the NIH trials came out to use IV TPA. TPA is tissue plasminogen activator, and it's a drug that will dissolve a clot, the lysis. And by doing that, you hope to improve the outcome of a patient who's just had a stroke. Later in 2013, there was some distressing news about the use of other interventions, such as the use of endovascular interventions, which I'll go through in some detail. And then in 2015, this all changed, literally 2 to 3 weeks ago, which makes the timing of this talk very, very opportune. So this is what we're trying to avoid. We don't want this to happen. And when it does happen, we want to try to intervene right away. The timing really is everything. If you look in detail, the really foundation of stroke treatment in the ER really goes back to this NIH trial back in 1995 using tissue plasminogen activator in a controlled double-blinded study. It started because there was some anecdotal evidence to suggest that TPA would improve the outcomes in patients who have a stroke if given intravenously. So this study, which was so seminal, was a randomized double-blinded trial using TPA within 3 hours of the onset of a stroke. First part of this trial looked at 291 patients and were given TPA as indicated when they had a stroke, and they were looking as a primary endpoint whether or not their NIH stroke scale, which some of you may or may not be familiar with, but by the end of today I'm sure everybody will be. But when their stroke scale improved by 4 points, they considered that a good outcome if it happened within 24 hours. So that was the primary endpoint. The second primary endpoint was looking at 333 patients, looking at basically some statistics, looking at their functional disability before and after giving TPA. This is the most commonly used one, the modified Rankin scale, as well as the Glasgow-Coma scale, and also the NIH stroke scale were used in that statistic to see if TPA would be helpful. Now, the result of that study, to make a long story short with that, there was no significant difference when giving TPA in the outcome of the NIH stroke scale after 24 hours. That was a bit of a dud. However, if you look at patients 3 months after being given TPA, 30% of them were more likely to have minimal or no disability than if they weren't given TPA at 3 months. That was the whole basis of the use of this wonder drug. That may be considered a small difference at 3 months. Basically, the major difference in the modified Rankin scale was that they had 1 degree of motor strength difference, meaning if you know the scale in neurology, that motor strength is 5 over 5 if you have perfect strength, and 4/5 if you have less than normal strength, and if you can do anything against gravity. But if you do things only within the plane of gravity and can't do anything against gravity, it's 3/5. So you basically improve one scale, one number, with the use of TPA on average after 3 months. So a modest improvement, but it was the only drug that ever really made a difference in treating stroke. And there were many studies over the last 30, 40 years, some which I've been involved in. One included dextromethorphan, the active ingredient in your cough medicine, which will make you hallucinate if you take enough of it. And I've had patients on that particular study back in the 90s who took it right after they had a stroke. I even had a doctor who actually took it himself on his own because he knew the study was ongoing. And he had a minor stroke, but actually hallucinated quite a bit. It didn't work. And numerous other drugs in the 90s and in 2000 decades, including other types of clot busters, NMDA receptor antagonists, made absolutely no difference in stroke. This is the only one that really made a difference. But if you look at even the difference with IV TPA, at 36 hours after giving TPA, you'll find that 6.4% on average in this NIH study had a hemorrhage in the brain as compared to only 0.6% of those patients who had gotten placebo. So the increased morbidity and mortality due to hemorrhages were quite obvious due to TPA. However, taking that into account, there was still this 30% improvement in functional outcome at 3 months. So therefore, TPA was approved for use and has been being used since 1996 for that. Mortality also was 17% in the TPA group as opposed to 21%, only a modest difference in overall mortality, and only slightly, not even significant. That was at a P of 0.3. So not even that much, very significant. So timing is everything in treating stroke. You want to treat it, at least back in the 90s and the early 2000s, within 3 hours. And later now, we opened up the window to 4.5 hours based on some other studies. But timing is everything in getting these clots out of people's arteries. Nothing really much happened, in my opinion, over the next 15, or I should say 13 years, as far as revolutionizing the treatment of stroke. They've been doing endovascular procedures, that is, doing catheterizations up to the carotid artery, up into the brain, to try to either remove or dissolve clots directly within the brain and the arterial system in the brain, most often the mid-cerebral artery or the basilar artery. And it had been done for years, but there really was not any convincing statistics that it worked. But it has been done sometimes as a Hail Mary and sometimes through small studies that suggested its efficacy. Then in 2013, at the International Stroke Conferences and other conferences, they presented data from what's called the IMS3 study. And this is an endovascular study that basically showed if you give somebody IV TPA in the emergency room for the treatment of a stroke based on the NIH protocol that we talked about, and you see if they improve or don't improve, but then you add on endovascular treatment, either giving intra-arterial TPA directly into the brain, right at the MCA artery or the basilar artery. You do that procedure after. Would you or wouldn't you get any better outcome? And they found from the study, and quite robustly, they found that there was no improvement in overall outcome of patients when intra-arterial TPA followed up with either when intravenous TPA was followed up with intra-arterial TPA or intra-arterial retrieval of clot. So through that same catheter, you can also place basically something that grabs the clot right out of there and retrieves it and pulls it out and takes it away and opens up that artery. So this was very disturbing back in 2013, and it almost signaled either a decline, and it really did scare a lot of people that there would be an end to endovascular treatment at that time. The conclusion was that IV TPA should remain the first-line treatment, and it was very disappointing to the people who were doing intra-arterial TPA that endovascular therapy, it was really something that would be helpful. But the authors of that study felt that their data was very robust and was very significant. So that was not good news in 13. There was another study called the synthesis expansion that basically mimics that finding and showed that if IV DPA was the standard, half of the patients still die or recover incompletely. And endovascular approaches, being used for years, had shown that you can recanalize the vessel. If you endovascularly try to open up that vessel either by retrieval or by dissolving the clot, you can open up that vessel by more than 80%, as opposed to just plain old intravenous therapy only opens it up by an average of 46%. But there was no evidence to suggest that recanalization of that artery made any difference in the outcomes, either mortality or morbidity. Again, pretty distressing that another study back in 2013 really found no difference in the endpoint of survivability or disability. So strangely enough, before this lecture, this talk was even actually put together, and the concept of having everybody come together, sometime about 2 to 3 weeks ago, the International Stroke Committee met again and discussed 4 new trials. And in a nutshell, the outcome of that led them to a very, very definite statement that there were some positive endovascular trials that heralded a new day in stroke. And I don't think this is too understated. Now I'm going to show you the data from those trials to show you how things really have changed overnight for us here. And the timing of Dr. Allison O'Hara, who you'll meet later today, couldn't have been any better. She's an endovascular radiologist who does these procedures, the endovascular procedures, to remove these clots, either by retrieval or by intra-arterial TPA. And this data really underscores the need and the imperative to do it. And the ESCAPE trial, which was done over the last 3 years, basically showed there was a 25% absolute benefit in the amount of patients achieving a functional independence when endovascular treatment was used. In more detail, what differed from these trials from the previous trials is that they looked at several factors that really make a difference in choosing our patients who get endovascular therapy. Appropriate imaging is very important on how to select patients who are likely to benefit, and I'll show you a few things about that in a second. Fast times to treatment, okay? Fast times to treatment should include the efforts that are done in the emergency room, the efforts to get CTs quickly, and the efforts to deliver thrombolysis quickly. And those treatments in this ESCAPE trial were done on an average of 2 hours faster than were done in the IMS 3 trial. So clearly that added to the better outcomes, and clearly that's going to put the onus on us to do even better in speed. And the latest endovascular technologies couldn't be more stressed. You know, the removal devices, the retrieval devices were often called, are called the mercy devices, the first ones that came out. And over the years, we started to call them the no mercy devices because they didn't do that well. They often led to bad outcomes. But the development of new catheters has made a huge difference. And a lot of the blame for the IMS-3 was because a lot of people who were in that study had gotten some of these older devices that didn't do a very good job. In the ESCAPE trial, for details, I hope I don't bore you with the details too much at this time in the morning, but in this study, 316 patients with stroke with large artery occlusions were either randomly assigned to get IV TPA or TPA plus either intervention with intra-arterial TPA or the endovascular retrieval devices. But you'll see that a lot of people, most patients, 86% of them actually ended up getting the retrieval. So in this later trial, in the last few years, more and more centers who were involved in these studies had these retrieval devices. The use of more sophisticated CT techniques makes a difference in choosing our patients. something called multi-phase computer tomographic angiography, kind of a hybrid between our CTAs that we use right now and something called CT perfusion. We use to exclude patients who might have had a very large infarct. Patients have a very large infarct, whether you're giving IV TPA or you're doing intra-arterial TPA. If you reperfuse that very large infarct, much greater chance of having a hemorrhage in the brain. So if you exclude people early in the ER because they have a huge infarct or they don't have good collateral circulation, you're much more likely to get a better outcome. And this is what we need to do. Collateral circulation, the analogy, which you might be more familiar with, is in the cardiac situation, is that when the left anterior descending artery begins to close down slowly over time, because you eat a few too many burritos or whatever, so in our lifetime, so as it slowly closes down, the heart starts to have angiogenesis of new vessels in other spots in the heart that begin to take up the slack for the lost vascular flow to the heart. So the collateral circulation, collateral arteries. In the brain, the same thing happens. If you begin to get arteries that begin to close down in the brain, if it's slowly enough, not an embolus, but a thrombosis, slowly, arteries from the external carotid will start to proliferate and feed the brain. Arteries from around the eye, the orbital veins and arteries, will begin to take up the frontal lobe of the brain, and your arteries even from the occipital area, from the scalp, so that the scalp will begin to grow into, from the occipital area into the brain in the back, forming collateral circulation. It's good to have collateral circulation, a backup plan. So if you can show that that's intact, your outcomes can be much better, and you'll do better with intra-arterial TPA. And also, in this intervention group, the mean time from CT to first reperfusion, meaning getting that clot retrieved or getting intra-arterial TPA into the brain, is 84 minutes, which is really quick. So just a word on this new technique, which I also have to learn about, but it's actually not that complicated. The idea is that this particular CT gadget in the ER, multi-phase CT angiography, is the most accurate way of figuring out whether there's an occlusion, salvageable brain, or collateral circulation. Basically what it does, it combines CT angio, which shows you the anatomy of the brain. It will show you that there's a clot sitting in the middle cerebral artery. When you see that clot in the ER, when somebody has an acute stroke, that's when you call it the vascular to get it out. The cerebral perfusion will show what the effects are on the brain because of that clot, whether there's any perfusion left in the brain due to it, and whether collateral circulation has picked up the slack on it. If you have an acute stroke that's large with no collateral circulation and no perfusion, you may want to avoid this kind of aggressive therapy. Basically, this is just software on your CT. It's just a big iPhone app, which we need to get. Radiation from doing these multi-phase CT perfusion scans is higher than doing the so-called single-phase perfusion, which is just a regular CTA. So we are exposing people to more radiation with this. But it's a small difference. But small differences can make a difference sometimes, too, in the overall radiation doses. And that's also a controversy in the diagnosis of breast cancer. Do we give too much radiation sometimes in the diagnosis and make things worse? But it's too early to really, I think, make any decisions or conclusions about the increased radiation risk in that. And it's a much smaller number of patients who will be getting it. So basically, you know, over the last 2 weeks, we had a history-making event occur in the field of stroke, which is going to change everything. They called it the biggest advance in stroke since the introduction in 1996 of thrombolysis. So I'm really glad to be able to tell everybody about that. And again, having Dr. Nahara here to do these endovascular procedures is just a coincidence that I am thrilled about. When you look at this trial, the proof of efficacy of doing endovascular procedures now is really relying on these two things. The functional scale of how people function after being treated for stroke the modified Rankin scale, which is the most commonly used one, as I said before, shows an odds ratio, meaning 2.6 times better outcomes than if you don't use the endovascular procedures. And more importantly, I think, the morbidity and mortality, not morbidity, the mortality of the endovascular group was significantly lower. I kind of honed this down to one quick statistical slide. The mortality of the endovascular treatment group was 10.4%. And then the control, who only got either TPA or no treatment, was 19%. That's almost a 50% improvement in mortality. None of the older trials in 2013 and before that came close to showing this. And this is what has gotten people so excited. Secondly, the ESCAPE trial also differed from other ones in that they allowed patients in not just at 6 hours or 4 hours, but also up to 12 hours after having their stroke. There were favorable outcomes for those people who came in at 12 hours and got endovascular treatment. However, only 49 patients were included that were in the 6 to 12-hour window. So they kind of hedged on it whether we should go to 12 hours. There's not enough data to make it significant enough. So I think 6 hours is the golden number right now. That was one study, and it's always good to have other information that backs up the same conclusion. The Extend 1A trial came out around the same time for endovascular treatment. And that study showed, again, 40% of patients had a good outcome with TPA alone, but that outcome was almost doubled when endovascular treatment was followed up with it. So similar findings as the ESCAPE trial. So rather than go through each trial, as they came up with these cutesy names like Extend 1A with the ESCAPE trial, the SWIFT trial, the Mr. Clean trial. All of these studies, showed convincing evidence that endovascular treatment following up after TPA, or even those patients who didn't get TPA, who just got it without TPA, had very favorable outcomes. I think this is very convincing that there's now a real imperative to give TPA when appropriate in the ER. There always was that imperative. And the Department of Health across the country, including New York State, has been trying to get people to do that for many, many years. Now, the follow-up with endovascular therapy when appropriate is another imperative, which over the next 12 months you will see a great deal of hype about in the news, and I think rightly so. Any questions about this, what I feel is the core of our thoughts going forward? Yeah.
Clarify exactly what are the benefits. I mean, I understand that generally the benefits, but I couldn't understand in what way is beneficial.
Yeah. Okay. So maybe I kind of glossed through that too quickly. The benefits in stroke trials are usually described as either benefits in functional outcome. So the modified Rankin scale is a scale of multiple measures of outcome. The ability to walk, the ability to talk, the ability to feed yourself, the ability to comb your hair, things like that. So it's a scale. So IVTPA just alone shows an improvement in that modified Rankin scale when you give IVTPA, and about 30% improvement after 3 months. Not initially, but after 3 months. But the use of intra-arterial TPA in function is considerably higher, double the amount of improvement at 3 and 12 months. More importantly, when you give IVTPA as compared to giving it following intra-arterial TPA or retrieval of the clot, the mortality, just plain out death, is improved from a mortality rate of 10.4%, from 19% in the controls who don't get endovascular, down to 10%. That's a 50% improvement in overall mortality. Again? mortality in 12 months. I have to remember the trial. It's 12 months. At 12 months, the mortality rate is down by 50%, which is huge. That's never been shown before. It was shown in 2 studies, at least. But that is the focal question here, and that's what I'm trying to drive home. That this is not an exercise. My favorite studies, like the Framingham study. Everybody hear of the Framingham study for the treatment of MIs and strokes? Framingham study was done, I think it was on 10,000 doctors back in the late 80s and 90s in Framingham, Massachusetts. And they looked what happened after somebody had a heart attack, and they gave them aspirin, and they went to see whether giving aspirin will stop secondary MIs or secondary strokes. Well, they looked at the data, and they saw, wow, the people who take aspirin after a stroke have less strokes secondarily if they take aspirin as if they didn't. So what they didn't really overly stress is that improvement is about 1%. It's a huge number of people when you take 10,000 people in a study. That's 100 people, right? 100 people. You saved 100 lives. But it's a 1% improvement over what it was before. And then my favorite study after that was the studies for Plavix. Plavix is 20% better than aspirin in its efficacy in improving secondary strokes. Well, it went from 1% to 1.2%. And they marketed Plavix and aspirin, like as a godsend. But there are some realities to what we do. This is entirely different. These are really big numbers. And so it's really, I don't think it's bubbled up to the surface yet in the popular press, but these numbers are going to change a lot of things in the next 12 months. Yes, yes. Oh, yeah. Yes. I asked Dr. O'Hara that yesterday, just to make sure. I almost stupid. So, yes, they have a plethora of different stents with cool names, and the names sound like, the orders extend, and they sound somewhat like an action movie or a pornographic movie. Some of these, they pick these great names that really just stick out in your mind. But yeah, they have a whole variety of them, and yeah, you can't do it with the old Mercy devices.
Now, will they get both PPA and they'll also get
the idea is that you pick and choose your patients. So, for instance, how many times have we had a patient in the ER who had an INR of 1.7, had a big stroke, and you say, darn, can't give him TPA. So you don't give that TPA to that person, but you do send them up to the intravascular lab to get it retrieved or give intraarterial TPA right to the brain, because the risk of bleeding is much lower. It's not nil, but it's lower than if you give it systemically, because systemically is where people bleed in their gut, et cetera. So some people will get TPA and then endovascular treatment. Some people won't get TPA and still get endovascular treatment.
They won't get both.
Many, I'd say the majority will get both. The majority will get both. That's the ultimate treatment. These studies, remember, were those patients that got the TPA and then followed up by endovascular treatment. But again, you have to select out those who can't get TPA because it's contraindicated because of a recent surgery, which will make people bleed, history of GI bleeding, a history of having an INR that's high, people on Eliquis, people on Coumadin, anything that will make them bleed more. Yes. Yeah, I thought about that as well. Can you prove that let's just bypass, this silly intravenous thing and go right to the thing that works? And it makes a lot of sense to ask that question. But, you get into an ethical dilemma these days on this, okay? If you have a proven therapy and you don't give it to them in the ER, there's an ethical bind to doing a study like that now. I think, though, perhaps studies could be done now because the proof here that we have here that the intraarterial treatment is so effective that maybe we're doing people more harm by giving the IV TPA because there's a systemic effect. and we can avoid that by going right into arterial. So I think maybe now they can form that study, but you couldn't really do that study before. And you get into ethical dilemmas like that all the time. Like treating, I treat a lot of patients with epilepsy. You treat patients with epilepsy who have status epilepticus and they're in continuous seizures. Well, for years, we've been giving Dilantin to people to treat status epilepticus. Now, how do you find a drug to treat status epilepticus and test it if you have to withhold the standard of care that's been used for 50 years, and you can't do it? So all the studies that are done where you give a lower dose of Dilantin or a low dose of Depakote, and then you use the new study drug. So it's very hard to do these studies now, but that's one of the dilemmas. But I bet you they can do it now, and I bet you we start to see those kind of studies soon. Yes?
Is there a certain amount of time you have to wait after the PTA is given? Go to get vascular?
Sooner the better. Yeah, the sooner the better. You want to get in there, and timing is everything. I feel for these studies, but the old expression is to be time is brain. The longer you wait and there's no perfusion, the worse off you're going to be. Yeah. So with that, I'm going to show you something a little bit more mundane, if you don't mind. There it is. As everybody knows, there's nothing worse than watching the Cerner time out. There it is. So let me find my. Don't worry, these are big patients here. So I wanted to use apparatus slide, but they wouldn't let me. Trying to, oh, there it is. What I'd like to show you is just procedurally for the doctors and nurses who are here working at Vassar. What we've done just to streamline everything, to make things a little bit more regimented, so we don't miss things. The Department of Health and the Joint Commission are big on, completeness and not missing anything, to their credit. But it makes us a bit neurotic, but we have to do it. We've created some order sets. Now we got to make sure everybody uses it. We had nearly 100% use for quite a while. The last 6 months, we've kind of changed our procedures at the hospital and tried to make neurology more of a consult service than an admitting service. So our task now is to get back on board using these order sets so that not only the neurologists use it, but also the internist and whoever the admitting doctor is. But that doesn't mean the neurologists are off the hook. They need to also use the order sets. In fact, I've asked them to be on top of it and double check it and make sure it's done by them if it's not initiated in the ER. So there's basically two sets of orders. One if you're the admitting doctor, and one that's called a module if you're the consulting doctor, like the neurologist or neurosurgeon or interventionalist, to do everything except like the admit orders. So if you type in neuro, you'll get this set of orders on the screen. And the ones that are important are, let me see if I can, yeah. So the ones that are important are really this. If it says just neuro CDA with TPA, that means it's an admission order set. If it uses the word module, it means it's everything but the admitting orders, but it's all the other important stroke orders. So this is if you got TPA, and this is if you got TPA, but you're just the neurologist adding the order set. If it's a neuro admission with a TBA or a TIA, what is that? This is the order set. And if it's a TBA, TIA without being admission, being an admitting doctor, it's the module. Okay, there are some other order sets for surgeons like hemorrhagic, CBA, and a bunch of other order sets for other neurologic diagnoses. This one also I'm going to show you the details of the hypercoagulable workup. So let's take a look first at the most commonly used one, which is neuro CDA, TIA without use of TPA. And again, the screen is a little low resolution, so the right side gets cut off, but I'll show it to you. Basically, it's going to ask you about the usual stuff about the resuscitation status, as well as patient status, where the patient is going to get admitted. But you see those are checked off and you can't be bypassed. Very importantly, the NIH stroke scale is going to be up there, and you cannot finish these orders unless you put in your NIH stroke scale. The NIH stroke scale should be done by the ER, by the doctors in the ER. We're working on that, okay? They're a busy group. They sometimes don't do it. I think they need to get on board and do it all the time. But the onus is also on the admitting doctor and the neurologist to enter the NIH stroke scale. That X means that if you don't put it in, you won't be able to sign up on your orders. Vital signs, pulse oximetry, neuro checks are automatically put in there, and they're done every 2 hours on the floor. Okay, and that's automatically done if you use these order sets. And in addition, at 24 hours, these orders can go down to 8 hours for neuro checks, unless you want to change it and be more vigilant about the patient, but that's automatically done in there. The nursing tasks, which I will go through, the VTE risk assessment is very important. That's in there. MPO status is dysphagia screen, okay, is in for every patient. It's often done in the ER. If it's not, it's done right on the floor. The worst thing is when somebody has a very minor stroke or a little bit of software or it clears up and they're made MPO overnight and they're miserable and they can't eat. So that's a dysphagia screen early on really avoids that when it's really not necessary. Later on, that is followed up with a full speech and swallow evaluation. And the use of statins is very important. If statin is being used initially in the ER because the patient had a cholesterol that was high and was already on it, you can continue that. On the lab, you'll notice there's an automatic check mark for checking lipid panels. Because before discharge, if the patient has an elevated cholesterol or has high HDL, high LDL or low HDL, mandatorily they need to be on some kind of statin. And if there's an exception, certainly you need to put that in there and document it. It's not a big deal. Usually the test, none of this is really checked off as a mandatory test, but the neurologist or the admitting doctor should write those in. And finally, the stroke quality measures, and all of the consultants, the case manager, PT, OT, speech and swallow, already automatically checked. So, like I said, pretty simple things. If we use these order sets, I think it makes everybody's life easier. Also, it prevents us from missing things. That is an admitting order set. I just want to show you the difference between that and a module. The module is, again, used if you're not admitting somebody, but you want to assist the admitting doctor, and I've really asked all the neurologists to do this. It looks very similar. The only thing is not the admitting order. So if general admission orders are used by the internist, this should back it up with them as a module to help out. There's all the same thing. The NIH stroke scale, which we have the person put the module in, the neurochecks are in there as before, the MPO and the dysphagia screen, et cetera, and the reason for not giving Lipitor initially and the ability to give that, as well as all of the lovely tests that you want to do, and finally the use of PT, OT, and stroke quality measures, et cetera. The same thing goes for TPA. The TPA module and the TPA admission thing is just slightly different in that, you know, we're going to do somewhat quicker, not quicker, more frequent neurochecks every 15 minutes for that first 24 hours. You really want to make sure that nothing goes wrong in that first 24 hours, because hemorrhage usually occurs in the first 24 to 36 hours. And an admission to the ICU. Every patient is going to get admitted to the ICU after getting the TPA, intravenous or intra-arterially. And so I hope I didn't bore you too much showing the CERN, because you know what that does to people. Any questions about either endovascular treatment, or the rationale for it, or these order sets? I'm going to show you one more order set. Any thoughts or questions? show you one last artifact, which is, I think, very valuable for the docs. And that is a hypercoagulable workup. These are the most common reasons why young people have strokes. Old people have strokes for this reason too, but when you have a patient who's considered young, and you'll all be happy to know that means people under 60 these days. It used to be 50. But when you have a stroke under the age of 60, we consider that unusual. Strangely enough, when we looked at our statistics from the hospital a couple of months ago, we found that if you look at all the patients who admitted to Vassar over the last 12 months, and you look at the patients who had strokes above the age, I believe it was 80, and below the age of 50, so look at that. It makes up 50% of all the strokes that we have these days. So think about that. We usually think of stroke as being a disease of the old. Now we're seeing it as a disease of the very, very old, and also we're seeing it as a disease of the young, making half of all the strokes now. So stroke in a young person is not uncommon anymore, and I think it speaks a lot to our habits in our society more than anything, and preventive medicine that really needs to be worked on. But anyway, the anti-nuclear antibody, antiphosphorylated antibodies to look for typical causes in stroke in a young person that are related to immunological reasons such as lupus. The clotting factors, anti-thrombin 3, sedimentation rate, also, there you go. Anti-thrombin 3, sedimentation rate, and C-reactive protein look for other inflammatory diseases that cause stroke in a young person. This probably doesn't need to be in here. I only threw it in there because I guess they wanted to just screen people who might be pregnant before doing any kind of anticoagulation. But backcoagulating, the genetic things, homocysteine levels, MTHFR, a common cause of hypercoagulability, some of the protein genetic deficiencies, including immune activity and protophosphate genes, are all in there if you pick and choose your favorite. So hopefully that'll be helpful. Whether or not you want to have a hematology consult to follow up with that, I think is a decision that each individual internist and neurologist needs to make. I know a lot of neurologists will find an abnormality and treat. Some people insist on getting a hematologist involved, which I think is fine and very rational as well. So I'm going to leave you with that, and thank you for coming here. This is always